Welcome to the Gastro Girl podcast. We bring together patients, experts, and health advocates who are all here to help you optimize your health. Here's your host, Jacqueline Gaulin.
Hello, everyone. Well, as we all know, young-onset colorectal cancer is on the rise. And today we're joined by the amazing Dr. Suneel Kamath, a gastrointestinal oncologist at the Cleveland Clinic in Cleveland, Ohio. He's recently been one of the lead authors on a very exciting study that got a lot of press that looked at whether red meat and sugar are the cause potentially of young onset colorectal cancer. So we're going to drill down and ask him lots of great questions, but I wanted to welcome you, Dr. Kamath. So great to have you here on the show today.
Thanks a lot. Thanks for having me.
So first of all, this young onset colorectal cancer situation is not a good one. It's, every time we pick up another journal article or news, we're seeing this rise and it's alarming. So could you kind of set the stage and let us know, what's happening? What do the numbers look like?
Yes. It's definitely been an alarming trend over really about almost 3 to 4 decades now. This really started probably in the early 90s, maybe even late 80s. And it's been a steady rise. And I would say it was sort of imperceptible to begin with, where it was maybe by 1% or 2% a year for a while. But now that we've kind of see it, you see the forest, not just the trees, you kind of see that this has increased, it's more than doubled really over 2 or 3 decades. And what we're seeing, while a lot of that is people who are in their mid 40s, we are still seeing, a pretty big spike, even in people in their 20s and 30s, which is super concerning. We never think about colorectal cancer in people that young.
Yeah, I just read that in one of the latest articles that about 11% of all new diagnoses of colorectal cancer occur in individuals that are younger than 50 years old.
Yes, that's right. Yeah, and we think that share is only going to increase, really. I think it will soon be 15% of the total. It's rapidly going to become the leading cause of cancer-related death in people that are ages 20 to 49 will be colorectal cancer very soon. And that's a very alarming trend and something that we need to be more aware of, so that we catch these people having this disease earlier.
And what's even more alarming, and I can't wait till you can tell us more about this, is the number of patients that are affected with early onset colorectal cancer that are Black and Hispanic. What's happening in that population that's so alarming?
Yes. Yeah. I mean, it's definitely, really scary to see. Yes, that this has affected people of color much more so than the white population in the United States. And that's particularly concerning because these are communities that traditionally have not been given the best access to healthcare and have been affected by systemic racism and many other things that have sort of led to negative outcomes for them, for their health for many years already. And to see this now being added on top of it, really, is very concerning.
Yeah, and you said something that was really important about access to care. So most of these patients, and correct me if I'm wrong, are diagnosed in later stages, stage 4, and that's the most difficult stage, obviously, to be diagnosed, because the positive spin on colorectal cancer, if there is one, is that it can be prevented if it's diagnosed earlier. Correct?
Correct. Yes. Yes, if with screening, that's sort of the nice thing or the silver lining, I should say, about colorectal cancer is that the screening methodology, if it is a colonoscopy, is not only for early detection of the cancer, we can actually eliminate the cause of that by removing polyps. Polyps are the things that ultimately then turn into cancer later. And so the screening tests we're doing, the colonoscopy, is not only looking to catch cancer early, we can actually remove polyps and stop that cancer from ever occurring in the first place. And that's the trend we're seeing really in the older population. The incidence in people that are 50 and older is plummeting. And we definitely think a lot of that is because when you remove these polyps, people don't even get the cancer in the first place. And of course, that's the biggest win of all.
And so going back to the disparities that exist to this care, what would you say are some of the disparities that exist and how can we close the gaps here?
Yeah, I mean, I think the biggest one, I think about is in communities of color, the Black community, the Hispanic community, we really see that, um, you know, insurance coverage is often lacking and not available. And the number of clinics that are available, the number of offices that are able to perform these types of procedures, colonoscopy procedures and everything is much less. And so, all of that leads to, delays in people getting care or not being able to get the care at all. And doctors in these places, they're stretched very thin. And so, you can imagine if you have 15 minutes normally with the patient, and then now, you're running late, and now you're trying to squeeze this person in and take care of everything in 5-10 minutes. I mean, you just can't do that. And but maybe they don't bring up the fact that they're having, blood in their stool, or maybe they did, and then, you just didn't hear that part and had to move on too quickly. It's just, there's so many factors, when people don't have good insurance, don't have good, medical facilities nearby, even if they do try to bring up their symptoms appropriately, it's very difficult for that to really be addressed in the way it should.
That's really insightful, and it's hopefully we can do better with more studies that are and more actions that can be taken in the communities to kind of reduce the barriers to care. Now, when we speak about symptoms, can you tell us, what are some of the symptoms? And now these would be later stage symptoms, right? Because you wouldn't have a symptom necessarily, or would you? Before you're like a colonoscopy screening. So what are some symptoms that a young person, younger than 50, or anybody, but particularly we're talking about this demographic that are seeing this spike, like what should they be looking out for? Because they may think, oh, I'm not even 50 yet, and I don't have to worry about this, but yet they may see something in there. They may see some blood in the stool, or they may have weird pains. Like what are some of the symptoms that they should be aware of?
Yeah, so many of the common symptoms, fortunately, actually are ones that can occur early. So
good.
Blood in the stool is the most common one. The other one that we hear very often is a change in the stool caliber, or having a lot of difficulty in straining with evacuating your bowels. And much of that comes from the fact that the vast majority, probably 70 or 80% of young and early onset colorectal cancers happen on the left side of the colon, and the left side of the colon is closest to the exit, if you will. And so they're more likely to have blood and affect people's ability to move their bowels, whereas the right side is much deeper into us anatomically. And so those symptoms might be missed a little bit more. It might be kind of a vague abdominal pain, but for most, it's bleeding, change in stool caliber, abdominal pain. And then weight loss, I would say, is usually a much later finding, where people have, decreased appetite and are losing weight. That's often when the cancer's gotten to a more advanced stage. And, what I would tell people, on this point is, because constipation is not unusual in all of us,
Right.
But what I would say is keep in mind that constipation that goes on for 3 weeks, 4 weeks, 5 weeks is not normal. That should be something that happens transiently. You didn't have enough fiber for a little while, and you got backed up. That's fine. Everyone gets that, but it should go away in a couple of days. If it's going on for weeks at a time, something's actually wrong.
No, that's a good point. And one of the other things I wanted to mention and see what you thought about this was the family history link, right? We may not realize that an aunt or an uncle that affects us, right? So can you talk a little bit about family history and what we should be aware of as we think about our potential for our risk?
That's a fantastic point. I mean, when we talk about screening, the age, which is now 45 instead of 50, that population is what we refer to as average risk. And so that includes not having any family history of cancer. And so the reality is a lot more people are at increased risk of colorectal cancer that don't know about it. And there's an opportunity there then for us to screen them at an earlier age and catch these cases much sooner. So yeah, I've really been trying to advocate to people that, the next time you're at some family event, Thanksgiving dinner or Christmas, have that conversation, because I see all the time in my clinic, people say, oh, I have no family history at the first visit. And then once they're diagnosed, they go talk to people. And then it turns out, oh yeah, Nana did have X. And we talked to an Uncle Bob, actually did have colorectal cancer, when he was 59, and people didn't know about it or talk about it. And so, of course, if we had known about that in advance, we probably would have screened those patients earlier, And so I think I'm definitely a huge advocate, have that kind of awkward conversation at the dinner table to know really what your family history is, because then, once your doctor has an information, we can act upon it.
Yeah. And I think maybe nowadays, not that I'm so old, but I'm old enough to know that back in the day, I had Italian grandparents, and they hardly ever talked about their history of what, everything was kind of like really kind of vague. And then you find even with my own mom, who was a nurse, like they never really talked about their health. They were pretty much in good health, but you find things out later that you didn't know. So I think for most of us out there probably can relate to that it wasn't like a topic that we all talked about all the time. Like everything was fine, until it wasn't. So I think it's a great point that you make to kind of talk about it. And I think now that there's so much more with social media and just things that could kind of serve as a catalyst for discussion, like, oh, did you see that study about red meat and colorectal cancer? Does anyone in our family have that? Or, as a way to bring it up and share information. It's a different way to kind of start the conversation, maybe. So if you're listening out there, try that at home.
Absolutely. Yeah, I'm all for that. Yeah.
So speaking of, now we're going to get into your study because it's such an interesting study. And I know, as we said earlier, it got a lot of press, great press. It raised awareness about this important topic, but it also kind of maybe scared people a little bit or made them wonder. Even my friends, when I told them I was going to do this podcast episode, they're like, oh no, you can't eat red meat. Like, can you eat organic meat? And I want you to explain, like, what was the catalyst for your study? Like, what made you do the study, and what was the name of your study? Because it wasn't red meat, it was something else.
Right. Yes. Yeah. So what we were trying to do is, we've always suspected that there's some exposure, in our environment and our diet and other sources that is driving this cause, because the majority of young onset colorectal cancers, people who have them, they don't have, a strong family history, and they also don't have a hereditary, genetic cause for it. And so that makes us think, the rates of those aren't increasing. So there must be something different about, whether it's what we're consuming or what's in our air or other things. And so there's this technology that we refer to as metabolomics, which what that looks at is sort of the breakdown products of our cells, as they use energy and make the things that they need, the building blocks that they need. We can measure those breakdown products. And what's nice about metabolomics is it's sort of a bridge between what we're exposed to, but also then what's our genetics. If you imagine like 10 different people can all be exposed to soda, but their metabolomes will be different because who they are genetically is different. And so it's a nice way to kind of bridge that nature and nurture thing.
Well, that's a good way to explain that.
It's a really interesting technology. And so what we wanted to see is, were there differences between those who have early onset colorectal cancer and average onset disease? And what we found, was pretty interesting. The biggest difference we found was a carbohydrate breakdown product, which is called citrate or citric acid, which I think some people may be familiar with. This is a key element or amino acid in our most important energy metabolism pathway, for all of our cells. And we found it was much higher. The levels of that were way higher in those who had average onset disease compared to those who were early onset. So that was a really, really interesting finding. And the other thing that we found is that many pathways related to amino acid metabolism, protein metabolism, such as arginine was one example, and aspartate was another one. These are two very common amino acids in our bodies. Those were significantly more activated in those who were early onset versus those who were average onset.
Now, for those of us who aren't nutrition experts, are those components that are found higher in red meat?
They generally are found. So I would say they're found in any protein source, really. Okay. I would think they would be at a higher rate, certainly in red meat. And that is an association we've known for some time, which is not unique really to early onset colorectal cancer. It's any colorectal cancer. Definitely, it's known that red meat consumption is linked with increasing the risk of colorectal cancer. In fact, it's the reason why in Western countries, we do usually screen for colorectal cancer, whereas in some places in Asia, for example, they don't have to as much because red meat consumption is much less. And there are other cancers like stomach cancer and others that are much more common that they screen for. And so we've kind of always known, the dietary variations there must affect that in some way.
Interesting. So what would you say are the key findings of your study for us that are trying to understand the links that you're potentially creating here?
Yeah, I mean, I would say, to me, it's always about moderation. The main headline for this certainly was that it's red meat and sugar consumption is causing cancer. The same narrative that's out there, sugar feeds cancer, right? And it's not that. That's a very simplified, oversimplified version of it. And what I think is really happening is that these are also very energy dense, calorie dense foods often. Sugars often come with, fats and processed foods and whatnot. They're very calorie dense. Same with red meat, and I think it's not so much that the actual contents of those foods are the problem. It's that it is sort of an energy excess state that is really the driver of all this. And that makes sense, from the way cancers form. It is sort of our normal cells in overdrive that form masses that are bigger and growing faster and spreading to places that they shouldn't.
Yeah, it's like they're activating. It's like almost like they're giving them little jump starts to kind of go, right?
Exactly. So yeah, I don't really think that it's the meat itself exactly or sugar consumption and whatnot. It really is just sort of an overall energy overdrive state, I think, is the big takeaway.
And for like some people, just the way that they metabolize these foods, the way they're broken down in the body and how their impact on the cell, right? That's going to determine whether it's more activated to, for like a cancer to kind of like start to happen. And I'm simplifying it because I'm just trying to understand and be able to articulate it back so that our listeners who probably feel like me, like, okay, I want to understand this better, because we're not here to say, don't eat this or don't eat that. It's really about understanding the potential impact of what you're eating. It has different results, and we know this, on your body and on the cells, and also on potential cancer cells that could be activated. And you've seen this activation happening more in younger onset colorectal cancer patients.
Absolutely. So, yes, absolutely.
It's very interesting. And you also said in your study that this kind of opens the door for even more research in this area. I mean, it wasn't a tiny study, but it wasn't a huge study. So there's, lots of work to be done. And are there anything that we should be aware of, or should patients be aware of coming out of your research, other things?
Yeah, definitely. I mean, I think the next step is really aggressively looking at different exposures, behavior patterns, and things like that. So, for example, at Cleveland Clinic, we've started surveying people in terms of what their diet histories were, antibiotic use, other medications that they use, other health history factors and all that. Where do you live? Do you drive to work or bike to work? So we're really trying to drill down into what is it about what we call the exposome, whatever your body is exposed to in the world, what elements of that really are affecting risk for cancer. And I think, so this is sort of scratching the surface, honestly, I would say, as far as probably mostly related to diet, I would think. There's certainly a lot more, I'm sure, to it. And, it's getting back to, disparities again for 1 second too. I definitely think that it might be that this is kind of a confounding thing where, if you imagine people who have diets that have a lot of, red meat, processed foods and processed meats, processed sugars, there's often an association with poverty, low socioeconomic status, less access to care. And so it may not even be that these are the only drivers of what's happening. It might actually be sort of a global, what comes with living in a low socioeconomic state, air, and other factors, so it might actually be sort of a global picture that's all contributing to this.
Yeah, and especially in those populations where the income is low and they don't have access, they can't buy organic food necessarily or things that are cleaner. I mean, it's like this vicious cycle. So I really appreciate the research that you're doing and the education that you're doing. Like I said at the beginning, reading all the articles, and I'm so glad that your study got a lot of press because it raised awareness, and it really did. But we also want to bring down the reality of what you were saying in the study, that sometimes news channels make everything not necessarily accurate. You didn't say in the study, don't eat meat and don't eat, well, you never want to eat too much sugar, but you weren't saying that. You were just saying a possible causation, and that there's going to be ongoing research that looks at these things on a cellular level to kind of maybe figure out what's causing this. But in the meantime, what do we do with this? What do we do with this information? And what are the key takeaways for our patients and the providers who are listening?
Yeah, I mean, I would say, I think the big takeaways would be, again, I think everything in moderation as far as diet's concerned. I think if you can cut back on red meat consumption, on sugar, these are generally good cardiovascular things to do anyway, for overall health. Work on being at a healthy weight. I think is another huge part of this. Is what was suggested by the citrate level being pretty high, that again suggests an energy excess, which the biggest driver of that is obesity, really. And, that's a huge problem in the United States, with us being, more overweight and more obese than ever. So I think working on that. And then I would say, again, awareness, both for the, general public and also for us in the medical community. One alarming thing that I've read about recently was that most people that were young that have been diagnosed with colorectal cancer say they've talked to 2 and 3 different doctors over several months before they were finally diagnosed, and that's certainly, not a part of the picture that should be there. I think we as a medical community need to be more aware of this and be ready to, move forward with the right diagnostic testing quicker, so that we can catch people at a much earlier stage so that they're not being diagnosed at an incurable stage 4 state. So I think, I'm hopeful that there'll be more awareness in general about this being out there, because that's how we're going to, catch people earlier, and then also ultimately figure out why this is happening in the first place, and hopefully prevent it completely.
Yeah, that's really scary that they've gone to all these doctors and they probably weren't, they don't have colon cancer. It's probably something else. But you definitely, if you're not getting the right answers, or maybe you're not referred to a gastroenterologist, you should definitely ask to be referred to a gastroenterologist if you're having any of the signs and symptoms that, blood in the stool, constipation that's going on for longer periods of time, and things that were just mentioned in this episode. You have control to some extent of making those decisions and seeking out care from someone that's going to listen to you.
100%. I mean, I definitely think advocating for yourself is a big part of this. Speaking up and being persistent about getting the care that you need, because I think there is still this narrative out there that people are, quote, too young to have cancer, and unfortunately that's no longer true with colorectal cancer at all. And so I think it may mean, really advocating for yourself for some time to finally get what you need.
Well, thank you so much. You've been an amazing guest. You're doing great work. I really appreciate your time, and we look forward to maybe having you on the show again. Good luck with all your research and everything that's going on. We really value it and appreciate your time today.
Thank you. Yeah, thanks for having me.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.